cases and 983,000 deaths. In the United States, we were at 6.9 million cases and 202,000 deaths. Today, we added 1,191 cases in Minnesota for a new total of 94,189 cases. The median age of our cases is 35 years old. We added 6 deaths yesterday for a total of 1,994 deaths in Minnesota. 3 of these deaths occurred in residents of long-term care facilities, 2 in Hennepin County, and 1 each in Anoka, Cass, Freeborn, and Renville counties. The total includes 4 people in their 80s and 2 in their 70s. There are 340 patients currently hospitalized with 120 in intensive care. In terms of a testing update, the 1,191 new cases yesterday was the second highest day ever on a volume of 28,230 lab tests. The weekly change in cases is 7.3%, stable to the day prior and up from 6.1% the week prior. The weekly change in testing is 7.6%, down from 7.8% the day prior and 7.9% the week prior. The average testing positivity rate is 4.8%, slightly higher than the day before of 4.5 and the week before 4.6. We have been below the caution threshold for 13 days now. I'd like to do a bit of clarification and speak to our hospitalization data. On Wednesday, we had talked about some updates we were making to our reporting of hospitalization and ICU data, and we want to take a moment to clarify this as there has been some confusion about it. Hospitalization and ICU data can tell us some important things about the pandemic, including how many severe cases we're seeing and what our healthcare capacity is, how many beds are available. First and foremost, we want to be clear that the way that hospital capacity data is tracked at the SEOC and posted on the governor's website has not changed. Yesterday, we switched to reporting on daily numbers for new hospital and ICU admissions rather than our old reporting that was a static daily count of how many people were in the hospital or ICU on a given day based on what had been reported to MDH for that day. The old number was meant to help people understand how severe the disease was, but it was also telling people about hospital capacity, so it was combining several measures. With the change we made to our data yesterday, we're still providing the same level of information and transparency, we're just getting more specific with the metrics. We made this change because new hospital and ICU admissions data are more meaningful measures to tell us about severity of disease than just looking at how many people are in the hospital on a given day. When we see upticks in new hospitalization or ICU admissions, it's usually after upticks in cases and is an indicator that more people are experiencing symptoms from COVID, and these symptoms are leading them to have to be in the hospital or ICU. We know having an understanding for how long people are sick with COVID is important to understanding this disease better. So we are adding separate data about length of stay to our weekly report next Thursday. Having that broken out in the report will actually be more informative about how long people are in the hospital and allow us to see trends or changes in that area as well. Of course, we also want to continue to keep a close eye on hospital capacity and how many people are in Minnesota hospitals. The State Emergency Operations Center, or SEOC, has been collecting data on how many ICU and ventilators acute care beds are in use, as well as other healthcare supplies for months. So we already have good data to tell us about capacity. That information is already available on the state dashboard and will continue to be updated there. That data that the SEOC collects is based on beds in Minnesota hospitals. So it includes people from other states who might be in a Minnesota hospital. For example, someone from Superior, Wisconsin that is in hospital in Duluth, Minnesota. The data on the MDH website about admissions includes Minnesotans who are hospitalized in Minnesota or other states. For example, someone from Crookston, Minnesota, who is in the hospital in Grand Forks, North Dakota. But it does not include people from other states that are in the hospital in Minnesota. We know that everyone is more familiar with the old way we were sharing data, and so we're sorry if the change caused confusion. As we've said before, we're committed to sharing as much data as we can, and we want to make sure we're sharing it in a way that will allow people to really have a good and accurate sense of what is happening with COVID in our state. Pulling these elements apart and talking about them separately gives a clearer picture of this going forward. And with that, I'd like to turn it over to Assistant Commissioner Dan Huff. Thank you.
Thank you, Chris. The federal CDC informed us earlier this week that they decided to withdraw their field staff who had been part of the CASPR project teams in Minnesota. As you may recall, the CASPR project was a voluntary statewide survey taking place between September 14th and September 30th as part of an ongoing effort to better understand the prevalence of COVID-19 in Minnesota. The goals of the survey had been to understand how COVID-19 has spread in Minnesota communities, understand what caused the disease to spread in certain areas, and explore how COVID-19 transmission and infection rates differ among regions in Minnesota, identify the percentage of people affected with COVID-19 that had no symptoms, and improve health messaging to help stop the spread of COVID-19. The plan was that during the survey, teams of public health professionals would visit randomly selected households in 180 pre-selected sites around Minnesota. After agreeing to participate, one member of the household completed a questionnaire. All members of the household who consented would be able to receive a COVID-19 test using a swab to test for current infection with the SARS-CoV-2 virus and an antibody test using a finger stick to draw a few drops of blood to see if someone had been previously infected with SARS-CoV-2. That's the virus that causes COVID-19. Why is this happening? In short, the CDC determined the reception these teams were getting in communities was too often hostile. In particular, people of color on these teams reported being subjected to racial slurs. These team members were also concerned about the incident reported from September 15th in Eitzen, Houston County, Minnesota. In that incident, already covered in some news reports, a team of 2 CDC employees and a contract nurse were walking up to a house when 2 cars pulled up and boxed in the team's car. 3 men got out, and one had a holstered gun with his hand on it. The team felt that the intent was to intimidate and scare them, and that the community members did not trust our team was who they said they were. Racial epithets were used by the men towards the CDC staff. There were several other incidents where a dog walker or another neighbor questioned the teams and or yelled at them and threatened to call the police. Many of the individual incidents could perhaps have been considered misunderstandings. But over the past week, a pattern emerged where the CASPR teams that contained people of color were reporting more incidents than the teams that were comprised of Caucasian people. We need to emphasize that many of the team's interactions were actually very positive. We had some CDC staff who reported having great experiences in the field and enjoying contributing to the project and our understanding of COVID. However, some CDC staff, especially those of color, reported increasing feelings of anxiety with the field work. Given the uncertainty of the situation and the impact the incidents had on team members, CDC decided to demobilize the entire team. This is disappointing on multiple levels. Through the Casper survey, we had hoped to better understand how COVID-19 is spreading in Minnesota and how it is affecting people. That kind of understanding could have helped us improve multiple aspects of our response. We know people are hurting and people are frustrated. The pandemic has gone on a long time. We are all tired and we are all worried. We also know that some people disagree with the policies and approaches taken at times. But there is a difference between disagreeing with a policy or an elected official and taking out frustrations on a public health person who is trying to do their job and help the community as best they can. We know most people understand this. We hope that this episode gives us all a chance to take a pause and consider how we treat each other during this stressful time. The enemy is the virus, not each other. Mike, I will turn it back to you.
Thanks, Dan. Operator, we are ready to take questions.
Absolutely, sir. Thank you. And at this time, of course, just to remind everyone, in order to ask a question, please press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, you can press the pound key. We'll pause for just a moment to compile the Q&A roster. Your first question will come from the line of Jeremy Olson from Star Tribune. Your line is now live. Go ahead, please.
Hi, I have a question off the topic of what was just discussed, so I'll ask it quickly and then move on to other media who may have questions about that. With the coming of 2,000 deaths from COVID likely occurring this weekend based on trends, I just going to be writing about what that means. And among other things, I'm noticing it took us about 2 months to get to 1,000 deaths and about 4 months to get to another 1,000 deaths. And I just want to ask what you make of that. Have we gotten better at managing and treating this? Has the pandemic just lessened or gone in a different direction to a point that it hasn't been as severe? What do you make about the 2,000 deaths in total and the amount of time it took to get to that second 1,000?
Thanks, Jeremy. Well, I can tell you that today at the end of our operations briefing, we took some time to just be quiet and reflect on the fact that there were a number of really serious things that had transpired, including coming up on that milestone shortly of the 2,000 deaths. I think it's something that is sobering. And we took it that way, and we ended our meeting with a period of silence. In terms of the question of what does this tell us, I think there are a couple of factors. Certainly, I think that the virus is still dangerous. Our deaths continue to occur, and we continue to see deaths in all age groups. But I do know that early in the pandemic, that was when we were both focusing our testing efforts on our long-term care. So we were seeing many more cases, a disproportionate number of cases in that age group. And now we're seeing, as you heard today, our median age of cases is 35. So we're seeing many more cases in younger age groups. And so that makes a difference because we know that risk for COVID increases with age. The other thing, though, is that we have improved. Our ability to care for patients successfully has improved as the pandemic has gone on. And so that's definitely something to celebrate, even as we acknowledge the 2,000th death likely this weekend. So I think we want to acknowledge the positives, but I also think that people need to realize that COVID did not magically go away or get to be a better virus over the span of the last few months. There have just been some other factors that have contributed.
Thank you.
Thank you, sis. Your next question will come from the line of Dave Auric from Pioneer Press. Your line is now live. Go ahead, please.
Yes, hi, thank you. Back to the topic that Assistant Commissioner Huff was talking about today, and I'm wondering if you guys can speak to your own workers and maybe you personally, you and Chris, as well as other workers around the state, what sort of and what degree of threats and harassments have you guys experienced? Because this is not unique to this one group of CDC workers in Minnesota, as many of you know.
Dave, this is Chris. I'll just say that yes, I do receive threatening and hostile emails and sometimes phone calls. I will turn it over to Dan, however, to speak more extensively about the unfortunate incidents with Casper.
Thanks, Chris. So we in official public roles are sometimes subject to angry calls, angry emails. With, I guess, the anxiety and the stress that people feel now, this has definitely increased, and it has increased to a level that, at least for us, is unprecedented. Public health people are rather mild-mannered, do not seek the limelight, but are now being threatened in their communities, hostile comments made. Some of our inspectors, while in the field, have had to withstand verbal abuse, name-calling. Our hotline and our social media monitoring that we do at MDH, we often have to cycle people out just because of the emotional toll that it takes, because we want to hear from all of our residents. And when those are full of vitriol, it is taxing, emotionally taxing. I think it's, from my perspective, it's unfortunate. I know us to be good people in Minnesota, and I know that we, at our best, come together to tackle problems collectively, to problem solve constructively, and we are not at our best right now, and that is disappointing. It is hard when staff come to me or I hear of the words that have been said to staff, because they don't deserve that. They're trying to do their job that they have been assigned to do, and to do it faithfully, and to do it with compassion, and to do it with fairness and cheer.
Thanks. I wonder if you could, a little more specifically, are there sort of support groups by any chance that have formed within public health communities? I know Colorado had something that emerged because of situations like this, where they had like an internal support group of workers. Have you guys seen anything like that happen?
I can tell you that amongst the staff, we try to provide sort of our own internal support. And as I said, you know, like today we took some time at our meeting just to be quiet and reflect. We also, you know, try to insert humor and all kinds of things into our conversations and our planning just to kind of maintain a perspective. But we don't have a formal support group that's happening right now amongst our staff, although there have been a number of trainings about resiliency and, you know, burning out and all those kinds of things. So there's been a lot that's been offered to us.
Great, thanks.
And I will say, yeah, thank you.
Thank you, sir. Your next question will come from the line of Aaron Havanzadeh from WCCO. Your line is now live. Go ahead, please.
Hi, yeah, my questions are also about the CASPER project workers. I guess I'm trying to understand how Minnesota specific this problem is. I know the previous question alluded to, you know, workers in other states are going through similar things, but whether it's CDC workers or if you hear from other health leaders in other states, can you kind of compare how severe the issues are here compared to the rest of the country, or is it sort of typical in a way?
Well, I can start, and then Dan, if you want to add to this. We certainly hear from our colleagues in other states, and they do talk about some similar issues in terms of stress and you know, hostile comments, those types of things. So I think that in some ways this is universal because the stress that people in Minnesota are feeling, it's being felt across the country. I think what is particularly disturbing to all of us is that somehow you always think your home state is the best, and that somehow we were better than all of that. So, you know, it might have been happening elsewhere, but we're Minnesota, and we expected that our fellow citizens would behave differently. And so I think that is particularly devastating to staff. But I will let Dan comment as well.
No, I think you said that very well, Chris. Thank you.
And then just to follow up, has the CDC had to pull teams from anywhere else in the country?
So that's a question you'll have to ask CDC. I'm not aware of what CDC's actions are. I'm only my purview is in Minnesota. Now, you know, I do want to add that many Minnesotans have responded very positively. A neighbor of mine left a note on my doorstep yesterday thanking me, and that means a lot. You know, we are sharing news that I think many of us find disturbing today, but it is disturbing because it's not what we expect. It's not our normal. I would say that, you know, we are generous and good people in Minnesota. We take care of each other. We shovel each other out in the winter, and we bake hot dish when someone is sick. We are good. These incidents, however, are disturbing, and I ask that we search back down to those better angels of our nature and remember that we are good, and to, you know, pay that forward.
Thank you.
Thank you. Your next question will come from the line of Paul Scott from Forum News. Your line is now live. Go ahead, please.
Hi, thanks. This is probably for the Deputy Commissioner. 10 days ago, the governor released a statement of his expectation that candidates would respect crowd limits. Yesterday, the vice president was in the state, an indoors event that defied these limits, and a week ago, the president did the same. And so there's just this disconnect here I'm trying to figure out, which is what is the status of these violations? I'm assuming private vendors would face penalties for ticket events that defy this guidance. And so are penalties planned for the host of these events? And if not, is there a double standard here?
Well, that is a challenging question, and it's one that we're wrestling with. We respect free speech. We respect political speech. As you said, the governor has sent a letter and asked both campaigns, major party presidential campaigns, to please abide by and observe our rules. I will also allude to what the governor has said many times, in that in a civilized society, we operate on a social contract with each other, and that everything cannot be policed, everything cannot be a matter of enforcement. We ask all of our elected and other leadership, all of our Minnesotans, to work with us as we follow these rules. And I will just add that Commissioner Malcolm has spoken to this previously as well. So I would say at this point we have nothing further to add on that.
Okay, thank you.
Thank you. Your next question will come from the line of John Enger from Minnesota Public Radio. Your line is now live. Go ahead, please.
Hello. Yeah, basically, I know we were recently downgraded in Minnesota to uncontrolled spread status, but I'm not clear on exactly what that means in terms of the numbers and how it got that way.
Thanks. Yes, definitely not a title that we're excited about. My understanding is that uncontrolled spread status comes about because of the widespread community transmission that is occurring in Minnesota. So we are, over 36% of our cases have to do with community spread. And the group that makes these designations is a group of independent health professionals who are tracking the pandemic in the U.S. I would say that we're not surprised by the designation, certainly because of what we've been talking about in terms of the outbreaks we're seeing, the increase in cases that we're seeing. It's not surprising that we've gotten to this point, but certainly it's disappointing. And it certainly is a situation in which we can change this, we can make a difference if people are willing to, consider those painfully often repeated messages of masking, distancing, and avoiding large groups.
Excellent, thank you. So it's basically community spread. It's not the overall numbers necessarily. It's how those have been spread that gives it that characterization.
It's both things. It's both the fact that we have really, really high numbers. Our case numbers have really gone up, as well as the fact that we also are seeing a lot of community spread. So 36% of our cases are attributable to community spread.
Thank you.
Thank you. Your next question will come from the line of Todd McDonald from Prairie Public. Your line is now live. Go ahead, please.
Thank you, and good afternoon, everyone. Say, I was looking at the map here, and for Clay County, Minnesota, there's 1,371 cases, whereas across the river in North Dakota in Cass County, there's 543. Now, I know there's a lot of people that commute back and forth over the state lines and such, but is there a concern when you look at counties that are on the border, neighboring other, high count counties?
Thank you for that question. Yes, absolutely. And certainly we know that between Clay and Cass County, or the Fargo-Moorhead area, there is a lot of interconnectedness between those communities, despite the fact that, they're in different states. And we are concerned because we know that our neighboring states are also experiencing very, very high levels of COVID. So the fact that, there are high levels on one side of, the state line, that means that for the other side, that is a concern. So yes, we're watching what's happening in our neighboring states, and we know that particularly in communities where there are shared services and shared interactions like that it poses a risk for residents of both states.
Right. I kind of found it interesting because Grand Forks County in North Dakota has, I believe it was 250 cases, whereas Polk County, Minnesota, had 301, so relatively close to each other, despite the river being the dividing factor.
Right, and we have had, I will acknowledge that in Clay County, we have had a number of cases associated with, well, I shouldn't say associated with, but a number of cases in students and staff in our higher education institutions. I always want to be clear that in those situations, oftentimes the exposure comes outside of campus, but nonetheless, we have had a number of cases associated with the colleges and universities there, so that makes a difference as well.
Today we're glad to be joined by the first person to be released under the...
Thank you. Your next question will come from the line of Maury Clover from KMFB Fox 9. Your line is now live. Go ahead, please.
Yeah, I was just curious, do you believe that this, Minnesota being downgraded to this uncontrolled spread and seeing the rise in community, transmission and number of cases or do you believe that, kind of Minnesotans returning to school and kind of college students returning to campus, are those some of the factors, or can you talk about any of the factors you believe that contributed to this in addition to what you've already talked about?
Well, certainly we know that, with fall, with return to school and campus, those are all things that we're looking at. At this point, however, I think it's important to keep in mind that most of the transmission associated with those settings has occurred outside of the setting. So in other words, as I just mentioned with higher ed, yes, we're seeing a lot of cases in individuals that are associated with institutions of higher education, but oftentimes or most times those exposures have occurred outside of the campus, and that has been true in schools as well. We're seeing more cases identified in individuals who are in school, but oftentimes or most times that their original exposure came from outside the school setting. However, I anticipate that as school goes on, we will see more cases, associated with transmission in the school setting, just because there will have been more time for that to happen. But really, right now, the uncontrolled spread that we're seeing really has to do with, I guess, the outbreaks and the choices, the weddings, the funerals, the large events that are being held in which people are not attentive to masking and social distancing. So school certainly and fall certainly contributes, but at this point, the driver has been those other factors.
Okay, thank you very much. Appreciate it.
Operator, we have time for one more question.
Absolutely, sir. Thank you. For your last question, we have one from Ricky Campbell from KSTP TV. Your line is now live. Go ahead, please.
Hi, thanks. Yeah, I know you touched on this at the very beginning, just about hospitalization data reporting and things like that. Can you just kind of explain that and how it's not moving the goalposts, hospitalizations, current hospitalizations opposed to admissions, and how that helps guide our understanding of what's going on in this situation?
Sure. Well, as I said in our, kind of early comments, we have been reporting the two things. Let me restate that. The two things that are really important to know about hospitalization, or the two key points that are important to track, are capacity. So in other words, what is the capacity of our healthcare system to be able to care for individuals who need hospitalization and intensive care services? And so we can measure that by the capacity, the number of beds that are in use and the number of beds that are available. And so that's one important element. And the other important element that relates to hospitalization is disease severity. And so we want to know of our cases, okay, who has an illness that is significant enough that requires hospitalization, and who may have an illness that is so significant that it requires intensive care utilization. And so when we were including the number of people that were, in the hospital or in intensive care on any given day, it was really merging two concepts. It wasn't really telling you what you needed to know about either. So it was giving you a sense that, yeah, there's people in the hospital and people in intensive care. And so it sort of got at, yep, we're using some beds, but it didn't really get to the idea that people are being repeatedly admitted. So we have some people who are hospitalized, who are discharged and get hospitalized again. So it's not tracking that level of metric. It didn't give us information on length of stay, and that's something that we're going to be providing. And it didn't acknowledge, if people are, some people are going between, ICU, hospital, ICU. So our feeling was that by breaking this out, that we're providing those same pieces of information, because we have all the hospital admission data and ICU admission data back to the beginning of the pandemic. We're still providing information on bed capacity. That hasn't changed at all. And so we're still providing the same information. We're just doing it in a manner that is cleaner and that breaks out the two pieces, I think, in a way that is more understandable.
All right, and then just real quick follow-up. How about all the hospitalization data that was on there before? It seems that it has since changed, at least on the dashboard.
Yes, we changed out all the data because we couldn't switch the data in the middle and have 6 months of data collected one way and then start over. So what we did is we just switched it. So all the data on the dashboard from the beginning of the pandemic now represents daily admissions to either the hospital or intensive care.
Got it. Thank you.
Mm-hmm.
That's all the time we have for this afternoon. If we invite any reporters with additional questions to reach out to our communications office this afternoon. Have a good day, and we will be back with you again on Monday.
Thank you, sir. Thank you so much, presenters. And again, thank you, everyone, for participating. This concludes today's conference. You may now disconnect. Stay safe and have a lovely day.